Today, again, we are just thrilled to have Rena Courtney back. Dr. Courtney's coming back for a second time, and she's going to be talking a little bit about some of this co-occurring chronic pain and opioid use disorder stuff. So this is right up all of our alleys, so this will be great. Next slide. And these announcements, which we just do over and over. Again, if you have a difficult case, we haven't done a lot of cases in a while, although we're looking at doing another echo maybe next month where we just do 4 or 5 cases just for teaching purposes. We've been collecting a lot of cases to do that, so we may very well do that again. They're very fun. But feel free to send one if you have something really interesting that you want to have everybody chat about. Next slide. Again, our people coming to talk about overdose surveillance data, which is one of my favorite talks, is coming up in January 28th. So please don't miss that one. That one is always just kind of tells us what's coming down the pipe in our drug supply. So it's really great. And in February, a bunch of great talks. I'm actually going to redo the 7-hydroxy case discussion. I have a couple of epic cases of some massive doses of 7-hydroxy, and we'll kind of review 7-hydroxy, metragenine, and then kind of do a couple cases that day. We're really happy to have the Hennepin County Medical Examiner coming back in March as well. Many of you have seen him on here before, Dr. Baker, but he's been coming on for years. So lots of great talks. Next slide. Remember, if you have questions or problems, just feel free to email and talk to Erin if she's not on the beach at St. Thomas. And feel free to give us a call. Our phone numbers are there if you have questions or problems. I've had some great, interesting cases here lately, really good methadone questions just yesterday. So feel free to call. Next slide. And lastly, if you want to go to the Center for Opioid Resources, you can go there and find just about anything that you want. Again, sometimes easier to call and just there's things that we can get you if you need things. Don't reinvent the wheel if you don't need to. Next slide. And I guess somebody has some polls, not me, must be Katie. All right, which of these best describes your role? I think my staff would love to know what I actually do. So you can pick which is yours. And if everybody's wondering, about 37% are providers, and really about 70% are nurses and providers. So a couple of pharmacists too, which is always good. Another poll there, Katie? As part of your role, please check the correct box or circle. Most of you are working with patients. And while you're waiting for the next or last poll, oh no, that's the last one. Just remember that as you look at my background, I am actually right at the start of the Mississippi River. And many of you may recognize that thing that's up there that says it's 2,000 miles down to the all the way to the ocean. All right, so it looks like people are starting to get connected. So we will let Rena introduce herself, tell us a little bit about what she does, and let her get going with the talk. I don't know if you're going to share. Oh, she's sharing her own slides. So we will let her get going. And thanks again so much for coming, Dr. Courtney.
Absolutely. Thank you for having me back. I really appreciate the opportunity. So if you weren't here the last time, I'm happy to introduce myself again. My name is Dr. Liz Courtney. Rena is the first name if you're trying to look up publications and things. But I am the program director for the Prevail Center for Chronic Pain here at the Salem VA Healthcare System in Salem, Virginia, which is right smack dab in the heart of Central Appalachia. And we have got a really neat pain program that started back in 2021 and was deemed a medical breakthrough back in 2023 by AARP magazine. And then as a kind of a side project, we've really developed this innovative way of managing chronic pain plus opioid use disorder, which we recognize is a growing issue in this patient population, and really something that we've got a long way to go in learning more about. So again, I appreciate the opportunity to come back, and let's go ahead and dive in. Today, we've got a lot of ground to cover. We're going to talk specifically about the overlap between chronic pain and opioid use disorder. We're going to talk about the role for members of an interdisciplinary team when you're working with that presentation, both for assessment and for treatment. And finally, we're going to talk about an efficient way of managing chronic pain and opioid use disorder in that team setting. And I'll be able to describe some of the work that we've been doing here at the Salem VA. I do want to share a couple of disclosures and just things to keep in your mind. I don't have any financial conflicts of interest to disclose. However, this work was, or my research efforts are funded by a VISN 6 Career Development Award, VISN 6 meaning a region of the VA. And I'm a member of the federal government, so nothing that I say is a direct reflection of the opinion of the US government. My opinions are my own. So let's go ahead and dive in here. So I want to talk a little bit about this concept of chronic pain and opioid use disorder. Let's break it down kind of piece by piece. Chronic pain is defined as pain that has persisted for more days than not for 3 months or more. The reason for that 3-month line of demarcation is that if it's under 3 months, then usually the body is in some kind of process of healing from the injury that started the pain. Usually when we hit that 3-month mark, then the experience of chronic pain changes, and therefore so does our treatment approach. And what we've learned for chronic pain is that interdisciplinary teams is really the gold standard way to approach pain. Pain really impacts and is affected by the biopsychosocial model. So biological factors are at play. The typical things we think about, like things that show up on x-rays and MRIs, but also some other biological factors that don't get talked about as much, including things like sleep or nutrition or exercise. Over time, we're learning that these kinds of elements really do play into the experience of chronic pain and must be incorporated into treatment. For psychological, we know that, again, mental health really influences the experience of chronic pain. If they have comorbid chronic depression and anxiety, PTSD, which is very common in the chronic pain population, that actually influences pain as well. It exacerbates that experience of pain. And then spirituality too. We're learning that, and not to spoil it, particularly in this population, folks who have chronic pain plus opioid use disorder, spirituality is one of the #1 ways that folks are coping with their symptoms. So we don't want to ignore that in treatment. And then finally, the social aspects. Again, part of my work in chronic pain has been talking about how, again, my folks down here in Central Appalachia, and part of self-disclosure, I grew up in a rural place. The nearest mall was an hour and a half in any direction. So that's just kind of my lived experience. Folks where I'm from, when they've got pain, they're not able to do things like keep up with the farm. They're not able to keep up with the land, do all the chores around the house. And really, we know that increases stress, which increases pain. Again, not something that we typically think about in treatment, but we're learning that it really does influence the picture, and we've got to address that. For personal development, meaning like how they're spending their time during the day, one of the fastest ways to make pain worse is to get bored, right? To not do the stuff that means a lot to you. And so part of our work in chronic pain world is getting them back to the things that matter and making sure we're doing so in a really slow and progressive way. And then finally, the last area we talk about for chronic pain is relationships. Most of the time when people are in pain, they want to shut down and they want to shut out. But the more that they do so, the worse that pain gets. So like I said, you can kind of see from the last couple of minutes that there's lots of different things that influence the chronic pain experience, and therefore lots of things we have to take into account with chronic pain. Now, if you kind of switch gears to the opioid use disorder side of the house, most everyone here, based on the poll, are working with folks who have opioid use disorder. Most of the time, we're really focused on getting people started on medications for opioid use disorder. And that's really the gold standard treatment. There are some psychosocial treatments that are available, but most of the time the focus is on getting them on medications so that we can get those cravings and things under control. However, we recognize that oftentimes people are not adherent to buprenorphine, right, or Suboxone. I know a lot of you all are off camera, but feel free to pop on for a second. How many of you would say that that tends to be an issue in your clinic, that people aren't staying on those wonderful medications that you put them on? Yeah. Did you know that one of the #1 reasons why people don't take their medications for opioid use disorder is pain, right? They have this expectation that these medications are going to address their pain in the same way that opioids did in the past. And then they get frustrated when it doesn't. So they just stop taking them. So again, we kind of start talking about the overlap between these two issues. What we've learned, and I know on the slide it says 64% of those who are seeking treatment tend to experience pain. Those numbers really depend on a lot of things, but those numbers can be as high as 96%. 96% of those who inject opioids report persistent pain in the last 6 months. I'm going to repeat that again. 96%. Almost all of them are reporting persistent pain for the last 6 months. And for those who were, and you know, you kind of get into this thought about the chicken or the egg, right? And the struggle about which one came first. What we know is that when we ask folks who have both chronic pain and opioid use disorder, which one came first, 59% of them are reporting that they started using opioids to alleviate the pain, right? So oftentimes pain is really the origin of where this starts, and then we develop opioid use disorder and trying to manage that. But then when you have both on board, the impacts just magnify, right? So we know that folks who have both chronic pain and opioid use disorder, they tend to experience a higher disease and service burden. They also have poorer treatment outcomes. So chronic pain by itself is a risk factor for relapse for opioid use disorder. So we really have to pay attention to whether or not chronic pain is happening and making sure that we're getting folks in treatment. As I mentioned, chronic pain can come usually before for a lot of folks, but also can come after opioid use disorder. Again, depending on the data that you're looking at, there was one survey that suggested 61% say that pain led to the opioid use, right? So pain came first. There's about 55% of folks who said that pain played a major role in their continued use of opioids. And then about 60% said that pain motivated their increased dosage of opioids over time, right? They were kind of chasing this pain relief thing, which is how we ended up with an increased opioid dose. But the sad part is that only 48% knew that opioids could actually make their pain worse over time. I recognize that I'm in a room full of providers, and so I just want to pull the audience here, and feel free to use the raise your hand feature. How many of you all know about opioid-induced hyperalgesia and what that means? Feel free to raise your hand. Opioid-induced hyperalgesia, yeah. Only about half of your patients know what that means, right? So long story short, what we know is that long-term opioid use actually can lead to an increase in pain, which is really sad, right? These people who started using opioids to relieve their pain, turns out that that can actually increase the pain itself and make them really sensitive to these pain signals coming from the brain. So, so again, these two things overlap really, really often, and it can happen both before and after. If we're thinking about what kind of leads to this issue, right, where you have opioid use disorder plus chronic pain, we know that there's environmental factors, there's genetic factors, there's also neurobiological factors that are really overlapping. There's a great article that came out in 2022 by Hall. So I recommend that if you're interested in kind of learning what factors are driving these things. We got a long way to go in understanding this particular patient population, because what we're figuring out is that these treatments that were developed for chronic pain, for example, are not working so great for people who also have opioid use disorder. And the treatments that we have for opioid use disorder are not working that great for people who also have chronic pain. There's something different about them that we really do have a long way to go to understand. So if we're switching gears a little bit, I want to open this up for discussion. I recognize that this is, a community of practice. And so I wanted to get a sense from you guys. If we're thinking about your practice, how prevalent would you say pain is in your populations? And feel free to either type in the chat or come off mute, whichever way you prefer. if you had to give a percentage for like how many of your patients with opioid use disorder also have pain. 60%. Okay. That's right about on the money for what these other studies are saying. Feel free to type it in the chat. 50%, 80%. Yeah. Yeah. Half or more, 50%, 60%. Y'all think about this, right? Think about this. That means that every other patient that's coming into your office is struggling with this issue. But how many of you all have really been trained in how to address pain? Right? I got a few. I got one hand. Samantha, I saw you. Not many, right? So pain education is lacking in our medical education system, but it's really lacking in our addiction education system too. Believe it or not, like I said, there's that much overlap, but nobody's getting training in how to do both. Now, there are some treatments that have come on board, which we're going to talk about a little bit later, but I want to hear what your experiences have been with these patients, right? So if you're thinking back over every other patient that you have, how does pain play into it, right? How are these people different than the other patients that you tend to treat? Are they doing better in treatment? Are they doing worse? Are they more adherent, less adherent? Like, tell me how you all are experiencing this. And you can feel free to, again, put this in the chat, or you can unmute yourself, either one.
Harder to convince to get on Suboxone.
Yeah,
versus being
absolutely.
off of opioids.
Exactly. I cannot tell you how many times I've had that conversation, right? Again, we'll get into the clinic that we've built here that helps with that approach. But
I think that one of the big issues is other substance use in the patients who are actually having chronic pain using opioids, especially with alcohol. Mm-hmm. And in our addiction clinic, it's probably more than 50%, especially over the age of 65, that are also drinking for their pain, which really complicates it.
Absolutely, right. And if you think about the risk of using opioids plus alcohol, right? And a lot of them are using those substances to help with their pain. And then you run in and for sleep, you're right. And think about the relationship between sleep and pain. Think back to the last time that, even if you don't have chronic pain, the last time that you didn't get a good night's sleep, you were probably achy, right? That's exacerbated for people who have chronic pain. And so usually if you're not sleeping well, then pain is worse, right? And the worse that your sleep gets, the worse your pain gets. And this kind of goes backward and forward until you're really in a bind with both of them. So yes, this is an issue. And I will say, you're right, worse anxiety, depression, all those kinds of things. This shows up in the literature. These patients tend to experience worse clinical symptoms just across the board. And they tend to have worse treatment outcomes, right? They're not jumping into treatment in the first place. They're more likely to relapse on their opioids. It's just not going well. So challenges, we've already kind of dove into this a bit, thinking about getting them convinced to start Suboxone, thinking about keeping them in treatment. All these things can be challenges. Any other challenges that show up in your clinical experiences with this population of patients?
Expectations.
Oh, that's a good one. Tell me more. Expectations about what?
Well, I think the expectation of many of the chronic pain patients, and in the addiction clinic, I often get people who come from the pain clinics who have had difficulties with their opioids. And so their expectation that they're going to have zero pain, right?
Yes. That we're going to get them to magical zero, right?
Yep.
Mm-hmm. And it's interesting that you say that. I'm going to talk about treatment expectation for just a second. If you have other challenges, please do feel free to put them in the chat while I am on. A couple of things to keep in mind. Again, recognizing that most of you all have not received training in pain. We talk about the concept of placebo, right? We all know what that means. If I tell you that the sugar pill is going to decrease your pain, it will actually decrease your pain, right? There is such a concept called nocebo. Does anybody know what that means? Nocebo. No? Okay. In laboratory settings, when we tell patients that, for example, a drip of saline is going to increase their pain, guess what happens? It increases their pain, right? If you tell someone that something is going to hurt more, it's going to hurt more. So when patients come into this experience, right, where we've got to taper them off their opioids, where we've got to switch up their opioids, and they have this belief that that's going to increase their pain, guess what happens? It increases their pain. Right? So treatment expectations is very, very important, period. And something that we have to control for when we run randomized clinical trials for pain. It gets really complicated. Two, magical zero. Again, having the pain discussion. I have this patient conversation every day in the clinic. We will never get you to zero because if I did, it would kill you. And they kind of look at me like I have two heads when I say this. As humans, if we don't feel pain, then we don't survive, right? And I tend to give this clinical example, so feel free to steal it and use it for your patients. If I'm walking to my car this afternoon and I trip and fall on something and I sprain my ankle, but I don't feel pain, what do? I keep walking, right? And so then that sprain becomes a break. And then I keep walking because I don't feel any pain. And then that break becomes an infection. Then that infection kills me. So when patients come in and they tell me that their expectation is that I get them to zero, I say, I can't because I care too much about you. So setting that expectation up front with medications for opioid use disorder, incredibly important. If they believe it's going to get them to zero and then it doesn't, they ain't going to take the pill, right? Or they're not going to have the injection. Kurt, I see your hand.
I'm really interested with the work that you do because one of the big issues also with people with chronic pain is the habit and the ritual of taking their medications and changing that. And so you've got this behavioral change that you've also got to deal with.
Yeah,
So
no, absolutely.
Comment on that.
No, for sure. Change is hard, right? I'm a clinical psychologist by trade. Change is hard. We're not really good at it as humans. How many of you all made a New Year's resolution that's not going that well, right? We're already like halfway into January. So that's a great point. And I think pointing that out for patients and offering a substitute is really key, right? If you think about, sometimes we use the analogy of a stool, right? Sitting on four legs. If I pull one of those legs out and then just expect that this stool is going to be stable, guess what's going to happen? It's going to fall over. But if I replace it with something, then suddenly things seem a little bit more stable. Keep that in mind when I start talking about the Restore Clinic in just a few minutes, because really that's the concept that we're going with when we're working with this particular population, right? Instead of focusing on, I'm taking away something like your regularly scheduled opioid, what we're trying to do is have a conversation about, you know what, let's add something in, right? I'm just going to add something in. We're going to see how that goes. And then usually what happens is that I've got a little bit more wiggle room to pull back on those opioids. And they're a bit more willing because the conversation is, what can I add rather than what can I take away? And that can help. But great question. Any other thoughts about this? Any other challenges that you've noticed, or thing like when you see these patients, you're like, this is just different? Anything else? Okay. All right. Well, let's keep diving in then. So if we're thinking about my context, as I mentioned, I work at the Salem VA, right? So I work with veterans all day. And what we know from the literature is that when we're taking a look at veterans who have chronic painful opioid use disorder, they tend to have more mental health diagnoses. They tend to have more increased experiences with homelessness, worse medical conditions like comorbidities, overlapping comorbidities, higher opioid prescriptions, period. And they tend to utilize services more frequently. Again, this is data that was from the VA, but this sounds like exactly what you guys were talking about, right? These people tend to be a bit more complicated. Again, another layer of context for where I work is that we are a tiny VA in Central Appalachia. We are not a big place with lots of resources. So keep that in mind whenever I'm describing the clinic that we were able to get off the ground. We do have lots of barriers to care for our folks. The reason I included this picture is because if you look right in the center of Appalachia, right here in the blue, this little green area that's rural, those are my people, right? That's actually where I grew up. And these are the people that we serve in the catchment area for Salem VA. They tend to not have enough providers, right? Both in the VA and outside. Most of my patients have to drive 2 hours to get to my VA. And we're the closest pain clinic that we have in VA to them. Reliable transportation is an issue, right? The truck's breaking down. I can't get to my appointment. Drive time. Let's think about our pain patients who have to get into a car and drive 2 hours, right? The jostling that happens in the car and the stress of driving in the city for a lot of these folks that are living out in the boonies, that tends to exacerbate pain before they even can get to me. And then time, right? Well, again, let's do the math. It takes me 2 hours to get to the VA. Then I've got to find parking. Then I've got to, go to the appointment and I got to get there early. And so that's going to take time. The actual appointment takes a while. Then I got to drive all the way home. It's the whole day, right? I now have to figure out what to do about childcare, about time off of work, all these other responsibilities at the farm or whatever else I'm doing. So keep that in mind as I talk about the clinic that we built. I do also want to talk about opioids in Central Appalachia. We know that the opioid epidemic hit everyone. It hit Appalachia pretty hard. And so earlier this year, or last year, I'm so sorry. What we did was last year, we took a look at the data for Salem VA and folks who were getting tapered off of their opioids in primary care. And what we learned is that 36% of them died or experienced suicidal ideation within 1 year of even having a discussion about opioids. Some of them didn't even start the taper. There was just a discussion about a taper. And then 36% of them died or had SI. And it was double the national rate, right? So if you look at the data from the national samples, that's double what we'd expect. And 12% died by overdose within a year. And not a single person had a biopsychosocial treatment plan. Remember how I talked about how biopsychosocial factors are influencing that chronic pain experience? Not one of them had a biopsychosocial treatment plan. I say that with caution because this was before I took over. So now lots of people have the treatment plans. Things are going better. But this was the original data that we had. We also learned when we took a look at the national data that rural veterans are more likely to receive opioid medications compared to their urban counterparts. And we have figured out that this is true in civilian settings too, that people in rural settings can't access non-pharmacological care with ease. So they tend to take opioids at higher dosages and more frequently than their urban counterparts. So we've already talked a bit about how opioid use disorder treatment is mostly focused on medications, right? And there tends to be an issue with getting folks to agree to go on medications and then keeping them on these medications. It's sad. The retention rates for medication for opioid use disorder is abysmal, especially when you talk about, 6 months, 12 months out. It's abysmal. There are some psychosocial treatments that are available for opioid use disorder by itself. And I shared with you a snapshot from the VA and DoD guidelines for substance use disorders. And what I want you to notice about this box, right, is that if you look at this, if you look at the column, this is psychosocial treatments available for opioids. Notice how many things say NA, right? If you compare this to like alcohol, you got options, right, for alcohol. We don't have a lot going on for opioid use disorder. As far as psychosocial treatments go, we got a lot of work to do. Let's see. All right. Again, the second piece that I wanted to point out was the current guidelines that we have for opioids in the management of chronic pain, right? So again, we're talking about folks who might not have opioid use disorder, but they are using opioids and they have chronic pain. Couple things I want to point out here. One is that the person needs to be involved in non-pharmacologic pain treatment. That means something for their pain that's not medication related. The second piece is that if the person is having functional concerns, it's getting in the way of their life, that you really need to consider referring them to an interdisciplinary pain clinic so that we can take a look at this from a holistic perspective, given those different factors that we know can throw gas on the fire like we talked about. All right. So what I'd like to do for the next little bit is talk about a clinic that we set up here at the Salem VA called Restore. Again, I confess to you that Restore really was built as a side project for Prevail. Prevail being the thing that I talked about the last time, where we have different providers in the room, including a physician, a psychologist, pharmacist, PT, meeting with a patient to come up with an interdisciplinary treatment plan at the same time, like a one-stop shop. We recognized that Prevail was working beautifully unless the person had opioid use disorder and we didn't know it, right? What usually tended to happen was that we get 55 minutes into the 60-minute appointment. We had a beautiful treatment plan. And then the veteran looked at us and went, yeah, that's great. Now where's my pills? And everybody went, oh, right? So what we came up with was, again, this different project called Restore for these folks who have chronic pain plus opioid use disorder. It's kind of like a sister project to Prevail, in that we still have everybody in the same room. We have an interventional pain provider, a psychologist, and a pharmacist who meet together with the veteran to come up with a comprehensive treatment plan. Remember what I said, most of our folks are driving 2 hours to get out here. So this whole idea of, oh, you're going to see the pharmacist on Monday, you're going to see the psychologist next Tuesday, you're going to see the pain MD in 2 months. This is not a thing, right? Like, my people can't afford to keep coming up here all the time. So the concept was 1 hour with one team, and let's get it done. We also want a treatment plan as soon as possible, which is made a lot easier when you're able to get it knocked out. So this is the overall process. And this was described in a manuscript that was actually published earlier last year in Federal Practitioner. So you can read more about it if you're interested. The basic overall process is, number one, that this went in as a pain medication e-consult. So all of our providers here in this healthcare system have the access to this e-consult where they can ask a direct medical question. Like, for example, hey, my veteran has been on hydrocodone at this dosage for this long. Are they, eligible for a taper, or should we rotate? And then the pharmacist is able to provide some direct feedback to them and answer that question. The next step in that process is that a pharmacist would actually review that veteran's chart. And if they were seeing some signs of some things that made them worried that opioid use disorder was on board, for example, results of UDS that were not as expected. We talked about polysubstance use. So, for example, they had something else show up on their UDS, or I prescribed you opioids, but it's not showing up in your UDS, or, those kinds of things. Requests for early refills, these kind of red flags behaviorally, then what the pharmacist would do is place a return to clinic order. They would place a scheduling order for restore. And then we would see the veteran as a team and talk about these different, I'll actually go into the agenda here in just a second. So we'd meet with them as a team, and then we would really work on getting them referred to Prevail, which is our interdisciplinary pain clinic. And what we know from about a year of that pilot rollout is that 89% of the people that we had that conversation with agreed to go through with IDT. And in my humble opinion, the more exciting thing is that 50% of the people who said they would actually did, right? Like, they actually showed up to that first interdisciplinary team meeting and worked towards getting that non-pharmacologic pain management treatment plan going. So let's talk a little bit about what that service looks like. So when the veteran comes in the room, the first thing that we do is introductions, because let's face it, having multiple providers in the room is a little scary. So we do introductions. We kind of describe our name and our role. We try to crack a few jokes, right, to kind of lighten the mood a bit, because this is a really scary idea for these veterans, right? They're concerned that we're going to take away their opioids, and that's why they're there. They're in trouble. The next thing that we do is we set expectations. We set the agenda for what to expect for the hour appointment. And then a psychologist does a diagnostic evaluation for opioid use disorder, walking through, what this has looked like over time, when they started opioids, what their use has looked like, whether it's caused any problems. And then we do some patient-centered feedback. Kurt, I appreciated what you said about the patients that you usually see, right? It's usually, well, I had pain, so they prescribed some opioids for me, right? And I've been taking them sometimes exactly as I was prescribed. And so really, they haven't meant to do anything wrong, right? Like, they did exactly what the provider told them to do. And sometimes what we know from the literature is that they still end up with OUD. And so really having that conversation in a way that's non-judgmental, but just says, look, I get it, right? Like, you were doing what you were told in some instances, and we're still here, right? Like, this opioid use disorder, or the opioid use, is kind of taking up more and more brain space than it used to. And that's not your fault. This is just kind of the way these pills work, right? There are some, now, admittedly, there are some veterans who had some behavioral patterns that didn't help, right? So they were self-escalating their dose. They were, getting some pills from some other folks. Their intention usually to start was to chase the pain. And so really that's where I kind of focus on the validation part. Listen, you've been trying to get your pain under control for a long time and doing whatever you could to get this pain under control. What I'd like to do is talk to you about some options for pain treatment that I don't think you've known about up until this point. And then I describe for them the biopsychosocial model of chronic pain, and then the interdisciplinary team that we're able to hook them up with. I do want to share the vignette that I tend to share with patients because in my experience, and this is anecdotal data, like almost, I don't think I've ever had any veteran who looked at me and was like, no, that was stupid. Like usually this tends to get some buy-in for some non-pharmacologic pain treatment. So hang with me. Typically the way that I describe this is I'll say something like, okay, you've been in pain for a really long time. Give me the list. Tell me everything you have ever done to try to get this pain under control. And usually the list goes like this. Well, I've had 6 back surgeries. I've gone to PT 50 times. I've seen the chiropractor. I have, I've done my stretches that the PT told me to do. I've tried every opioid on the market. And on they go, right? And I literally will take a piece of paper and I'm writing this down as they go, right? One after the other in a vertical line. Once they finish, because oftentimes these patients don't feel heard, so I do let them kind of keep going with their list of things that they've tried. I say, okay, you know what I notice? I notice that every single thing that you mentioned is a biological approach to pain, right? It's based on this assumption that I can find the problem and I can just fix it. And unfortunately, what we've learned is that pain is super complicated, right? That there's some other stuff going on that we have to pay attention to, because if we don't, then we're not seeing the whole picture. But I want to make sure that this actually fits for you, right? So what I'll do is I'll write bio up at the top, and then I'll write psychosocial. And then I'll say, okay, let's test this out and see if this makes sense. I have 2 different x-rays from 2 different people. And my question is, do they have the same amount of pain? Right? The x-rays look the exact same, but they're from 2 different people. Are they feeling the same amount of pain? And every single veteran looks at me and goes, well, no. And I'm like, well, why not? If this is just a biological problem, then they should be feeling the same pain. And they're like, but they're different people. And I go, oh, so personality plays into this, right? Lived experiences plays into this. Their mood plays into this. All right. Okay. All right. So maybe some of this psychological stuff does influence it, but let's try one more test. What happens to your pain every single time that you get stressed, you get frustrated, you get worked up, or you're wound up tighter than a rubber band? What happens to your pain? And every one of them looks at me and goes, well, it gets worse. I'm like, well, hang on. If this was just a biological problem, that should have nothing to do with it. But because it does, okay, sounds like the psychological part does fit with your experience. But let's try one more thing. The social part. Nobody talks to you about this stuff, right? But what happens when you're in pain? Do you want to go out and play with the grandkids and go hang out with your friends and go on a walk with the wife? No, right? You want to shut down and you want to shut out. And the more that you shut down and shut out, what happens to your pain? And they go, well, it gets worse. And I'm like, okay, so here's the problem. It looks like up until this point, I kind of cover up the psychosocial part. You've been dealing with about 1/3 of the problem, right? And my concern is that unless we kind of address all of this, that we're not going to get you anywhere, right? We're not actually going to be able to tackle this pain thing. So that's what I want to get you hooked up with. I want to get you hooked up with a team that knows this concept, right? That knows how complicated pain is and how we have to attack this thing on all fronts in order to get you going, right? And to get this pain under control. And again, 89% of the people that I had that conversation with in this clinic, because I was actually the psychologist in the room, agreed to try it, right? And that's a win. The more non-pharmacologic stuff that we can get on board, then usually the more willing that they are to make some changes on meds. So after I've done that kind of motivational interviewing, education conversation with the veteran, then my physician and pharmacist who patiently been sitting there listening and kind of absorbing this veteran's experience, we'll talk to them about their medication regimen, right? They'll make some recommendations. Perhaps if the veteran does have opioid use disorder, then we're going to recommend Suboxone. But we're going to recommend it in the context of how it fits into their overall pain treatment plan, as opposed to just focusing on the OUD. It was interesting, not that long ago, an article came out where they did some focus interviews with folks who had chronic pain plus opioid use disorder. And you know what they said? They said, I'd be more willing to actually do what the doc said if they would focus on my pain, right? Okay, now we know kind of where we can hit, what buttons we can push in order to get some movement out of these folks. Focusing on how it's going to treat their pain as opposed to their opioid use. Trying to get that buy-in. And then we talk about treatment planning, and we use this shared decision-making model because we recognize that not everything I come up with is going to be the best fit for the veteran, right? I'm going to try to give you a list of options as much as I can so that the person can really dig in and figure out what's going to work for them in their life. All right, let me move on here. I don't want to pause. What are your thoughts on this? Like it, love it, hate it? I'm open to all thoughts. And I do see some questions in here. I might stop and address those. Good question about the virtual visits. At this point, we are not doing virtual visits. It's something that I want to do in the future. Sometimes what happens with these appointments is that we have to do a UDS or we have to do an EKG to get them started on some medications. And so we want to make sure they're able to do that work on the first day. We have in the past done some follow-up visits through virtual visits just so we can make sure that they're able to, again, access our clinic. But you're right about the changes for telehealth, and I'm very excited about that. I see that you're in a rural area, Samantha. Thank you for your work. And I've tried everything. Preach. Most of the veterans that I see have been in pain on average for 15 years. Most of them, in my anecdotal experience, say something like, well, I've been in pain for 40 years and I've tried everything. The nice thing about where I'm at is that I get to say, but you haven't tried prevail because we're a newer clinic, right? We came on the block about 4 or 5 years ago. So I'm able to offer that hope. The other thing that I recommend is remember that clinical vignette that I just gave you, right? Ask them to tell you everything that they've tried so that they feel validated and heard. And then explain how, all right, well, we're missing 2/3 of it, right? Like there actually might be some things that you haven't tried. Again, I'm going to try not to get on my soapbox for pain. This is what I love. But things like the anti-inflammatory diet, most of them have never heard of it, right? We've got a veteran who came into the clinic not that long ago who, once we got him started on the anti-inflammatory diet and we got him doing some exercise through our department, his pain did go to 0. Don't tell your patients I said that, but we actually did get him to 0, right? He wasn't having pain on a daily basis. So, it works. And what we know from a meta-analysis that was done, I think a year or 2 ago, is that the anti-inflammatory diet has significant impacts on pain. So there are options. And feel free to reach out to me if you need some educational resources. Kurt, yeah, jump in.
I'm just wondering with all the work you've done, because when, and again, I probably see a couple of 2 or 3 pain patients a week that come from different things. And one of the similarities I've seen and is the fear of going off the opioids, because to be honest with you, I think they're probably one of the best things for PTSD and trauma. And patients understand that when they stop taking their opioids, traumas come back. And we see that not only in the fentanyl group that's using illicitly, but I've seen this repeatedly in people with chronic pain, that the sexual abuse comes back, the bad dreams, nightmares. What's your experience with that?
We see it all the time. Remember, I work in a VA, right?
Yeah,
their trauma exposure is more than the average population. So we do see that all the time. I am spoiled as all get out because we have an amazing PTSD clinic here that's able to offer evidence-based psychotherapies for PTSD. And I trained with them for a bit, so I'm able to describe to folks what that looks like and able to get them engaged in those treatments. You're right. A lot of people are self-medicating some emotional stuff because think about what opioids do, right? They numb you, and numb feels a lot better than pain. Numb feels a lot better than anxious. Numb feels a lot better than sad. So yes, that makes sense. I think part of the tactic that I take with folks is, again, I'm able to provide some insights into some treatments that they might not have considered or known was possible, right? Some of them think that they're just stuck with PTSD for the rest of their life, and they don't know about cognitive processing therapy. They don't know about written exposure therapy. That's the new kid on the block. So I'm able to provide that information, but I think oftentimes I'm having this motivational interview and conversation with them where I'm like, you're right. It does make you numb. And it's your choice, right, to keep using these medications in that way. What does it cost you, right? Because here's the problem. You can't numb out and then still get the positive feels, right? Numb is numb. Once you take out the color in the world, then you also don't get the positive stuff. So again, gets me a little bit of traction for maybe we can look at this differently. But at the end, it is their call. This is the MI approach, right? So that can help. I did see some question in here about the pain physician. Yes, it is an interventional pain physician who has experience in anesthesia and also in addiction. And so we have had folks, right now, my 2 providers are MDs, but we have had a DO who had a rehab background. Actually, the MD that I have now still has a rehab background, but is also getting trained in addiction. So, okay. All right. Any other questions or thoughts, comments? All right, this is a lot. Y'all are doing great. Let's kind of keep going here and explain again the Prevail concept, because a lot of what we do is try to bridge to this non-pharmacologic care. So let me explain real quick what Prevail looks like. What we do is and I will say that this has changed over time. If you look in the literature, it'll say something like we do 6 weeks of pain education, and then we meet with 5 providers, and then they go through 6 months of a coaching program, and then they meet with the team again. What I have learned over time, being in the VA for over 10 years, is that you got to learn to roll with the punches and ride these waves out, and just be flexible with what it looks like in the current environment. So needless to say, it's changed since we first rolled it out. And really, some of it's been for the better. So for example, the pain school class that we offer used to be 6 weeks for an hour each week, mostly done over telehealth. Now that's actually slimmed down to 2 weeks. And that was based on veteran feedback. We had some veterans who said, I would love to do this, but I ain't got 6 weeks to do it. So we condensed it down to 2, and then created a list of written resources for them to review if they wanted additional information. Then they do the initial evaluation with a team. And again, if you look at the team, it's a pharmacist, PT, psychologist, and a pain physician. Notice the dietitian's missing. If you were there for my last presentation, I was talking about how we had a dietitian in the room. Then they got short-staffed in the service line, and they removed her from the meeting. We still have her available on staff, but that's a separate consult that we put in for most of our folks. Then they go through 5 months of coaching calls, and then they have a 6-month follow-up appointment. Actually, it's now a phone call with the nurse. So the nice thing about this is that with the change, technically, once they start Prevail, they only have 1 in-person appointment. The rest of it's done over the phone, right? And telehealth for the pain education, if at all possible, because again, my folks can't come up here all the time. The interesting thing about doing this talk now is that we're actually at the start of a really exciting expansion. So this started out as a pilot. I had good feelings about what was going to happen, but I didn't have any data. Now we've got a little bit of data, and we've got some investment from the leadership at our hospital to expand Restore pretty exponentially. So starting in about a month and a half, we're going to go from 4 slots a week, right? 4 individual slots per week to 9. And the implementation for the expansion is being supported by local policy. So basically, if folks are MEDD of 150 or higher, then they are required to be referred to Restore and for us to take over their medication regimen for at least 6 months so that we can put them through exactly what I just talked to you about and try to get them some non-pharmacologic treatment on board. We also are going to institute something called an opioid board. So what we often have in our hospital system, and I'm imagining this sounds familiar, is that you have somebody who comes in, they're on a high level of immunity. They want to go up. And so they go to primary care. Primary care says no. So they're like, no problem. Then they show up in the ER, right? And ER is like, no, I don't think that's a good idea. So they go to urgent care. And then they're like, no. And they just keep kind of bouncing around and until somebody tells them yes. So what we're going to be instituting is basically a board of folks who at our hospital are able to help with some medical decision making. So when we have talked to the veteran about needing to taper down, and they, after 6 months of MI and everything that we can try, they're like, no thanks. We're actually going to have a board of folks who look at the benefits versus the risks of keeping them on that dose versus changing it. And then there's going to be a note that goes into the chart that says, this is Salem VA's stance on their pain regimen. Don't touch it. And then we'll come back and kind of change things as we need to if the situation changes. But more to come. We're going to be gathering data on this as we roll it out in the next month and a half. So you guys are literally the first group of people I've told outside of the Salem VA. So we'll see. We're also going to be doing some measurement-based care, checking in with folks on a regular basis because we recognize that this may exacerbate mental health symptoms. It may bring some suicidal ideation on board. And we put in some safeguards to make sure that we're catching that and being able to treat it as soon as possible. I do want to share a couple of resources with you as we wind down here, just about measurement-based care. This is incredibly important when we're thinking about doing this comprehensively for folks who are at a high risk of adverse events. So if you haven't heard of any of these measures, take a look. These are very, very, very short. National VA came out with this thing called a PMOP measure set, right? PMOP being pain management and opioid safety and prescribing, something like that. Too long. We love our acronyms in VA. But these different measures think about this, 3 questions, right? 3 questions for pain. Pain intensity, pain interference with general activity, pain interference with their enjoyment in life. In 3 questions, I can get a really clear sense as to what their pain severity is and how much it's getting in the way. If we're looking at self-efficacy, can you feel like you can still do your life despite your pain? 2 questions, right? These are really kind of low-hanging fruit. And if you put it all together, you got a pretty good comprehensive sense as to what's going on with their pain. I recommend looking into this if you're trying to track how folks are doing. And then it can also be motivating for people. You get them for a baseline, you take a look at their pain and how all their stuff is doing. You get them started on perhaps medications for opioid use disorder. And then you compare. And you know what? You've been on this medication for 6 months, for 3 months. Let's see what these things look like. And you can talk about their progress, which might increase their motivation to stay on the regimen that they're on, or might inform your treatment plan about needing to change things up. I do also recognize that the stuff that I'm doing is in the culture of lots of different things that are coming out. So I want to give a nod to a couple of other things that are coming out in the literature that I'm excited about. One is this idea of this multimodal stepped care intervention. We recognize that not everybody needs inpatient domiciliary treatment for their opioid use disorder. So this is really designed to get patients integrated into the level of care that matches their needs and their wants. Mindfulness-oriented recovery enhancement. Raise your hand if you've ever heard of that. Mindfulness? Okay. This makes me sad, and I knew that this was going to be the response. Believe it or not, this is the one evidence-based psychotherapy that we have for chronic pain plus opioid use disorder. And it's supported by several clinical trials at this point, but nobody has access to it. So if you're interested in learning more about that, please take a look at Dr. Gartland's work. Again, several different RCTs supporting it. And then the last one is empowered relief. Again, raise your hand if you've heard of that one. Empowered relief? Okay. So I will tell you that empowered relief started out in the chronic pain world, and then they're starting to test it out with folks who have chronic pain plus opioid use disorder. Empowered relief is a single session, so one-time session that lasts for 2 hours. And it's really based off of cognitive behavioral therapy for chronic pain, as well as pain neuroscience education, teaching patients some basic skills to cope with their pain, teaching them more about pain. And here's the crazy thing, that in chronic pain patients, right, chronic pain only, not opioid use disorder, it's not inferior to 16 hours of cognitive behavioral therapy plus chronic pain. So that's our gold standard for chronic pain, and this is non-inferior with a 2-hour dose. 2-hour dose, 16-hour dose, wild. Again, it's got 11 randomized clinical trials supporting its use, and I'm really curious to see what happens whenever we get the data back for chronic pain plus opioid use disorder. We shall see. All right, and finally, last thing is just questions. So I'm happy to, if you guys want to come off of mute and you want to share any questions or concerns, there's a couple of QR codes if you're interested in learning more about Prevail. If you're interested in learning more about pain, I strongly recommend the one that's over on the right that talks about our whole health treatment plans. It pretty concisely summarizes the literature on different factors that are influencing the experience of chronic pain. So if you want to talk to your patients about pain and what might be an option for tamping that down, that third one is going to be your ticket. But again, I want to thank you guys for the opportunity for having me back. Thankful that y'all wanted me back, and I can answer any questions.
No, that was a fabulous talk. Let me just ask you if you want to comment a little bit on how interesting it is that if you look at isolated opioid use disorder, which is worsened by boredom, which is worsened by poor connections, which is worsened by whatever, how, in fact, if you look at addiction, isolated addiction, it is also affected by exactly the same things. And that the overlap on those two things is just, to me, just fascinating.
It is. It absolutely is. So I will share very early. My colleagues and I are working on a mechanisms paper where we're trying to understand kind of what's driving this issue in these people. Because you're right, they share a lot of things, right? Like the boredom piece and there's a lot of overlap in the things that drive them individually. But when you put these things together, these people are not responding to treatment in the same way, which makes me think there's something about them, right? There's something that's going on that we haven't quite figured out, which is why right now our treatments are kind of like throwing darts while blindfolded because we don't know what we're trying to hit. So we can't hit it. So hang tight. We've got a lot of work to do. And if you're interested in collaborating, then feel free to reach out. But thank you very much for your kind words in the chat. You guys are great.
Any other questions for Dr. Courtney?
There was a question in the chat about if the interventional pain specialists do medications and procedures or just do one.
Both. So the way that the grids kind of look for my folks, and I will unashamedly put in a plug, we're hiring. We're going to be hiring soon for another paid MD to join our team. But basically the way that their schedules kind of look is that they're involved in 3 different areas, right? So we have a portion of their time in Restore where they're doing medication management for these folks who are with chronic pain and opioid use disorder. We have them in Prevail, where they're doing non-pharmacologic treatment plans for veterans and providing them with feedback on whether or not interventions would be a useful addition to their treatment plan. But then the rest of the time, they're actually doing injections in an outpatient clinic. So the answer is yes, they're doing all of them. We train them up like a bunch of Swiss Army knives. They can have many uses.
How do you work with someone who, like, if interventional pain will only just do like injection, surgery, like how do you overcome that?
We have that conversation during the interview, so that way they don't come here if that's not what they're interested in. Really, I mean, we're very selective on our team members. We bring on the cream of the crop, and I'm very protective of the dynamic that we've developed on my team. So they wouldn't be happy here if they're only interested in doing interventional pain. Let me put it that way, because most of what we do is not that. And I would argue that actually when they're having that conversation with the veteran, when they're giving an injection, they better be talking them into the IET clinic. So they would not be happy here. Great question about the outcome data available for the program. Again, for Restore, I recommend taking a look at the manuscript. We don't have long-term outcome data. We're actually putting in some grants on that front. For Prevail, we are finishing up a randomized clinical trial right now, actually. And so we've got 2 papers coming out. We've got one that's taking a look at some clinically ascertained data from just the clinical program. And then we have the clinical trial outcomes that'll be coming forth soon. So, great question about spirituality. And I recognize we're coming to the end of time. I'll be fast. So what we do during the Prevail conversation is that during the intake paperwork, we actually ask them if spirituality is important to them, right? If the answer is yes, then we ask them if they're engaged, or we ask them what role that plays in their life, if they're connected to a spiritual community. We actually ask them to kind of give themselves a grade on how they're doing in spirituality as part of everything else, right? We ask them to grade them on how they're doing for exercise, for diet, for mental health, for keeping up with the farm, all that good stuff. So that's just part of the conversation, and it actually sits right in the middle. And part of that is just to normalize it as part of the conversation. We recognize that this plays into the experience of chronic pain for folks. And so we want to understand if this is throwing gas on the fire for you. If it's not important to you, then we skip it. But FICA, I want to make sure I'm not saying that wrong. I believe it's FICA is the standardized instrument that we use to assess for spirituality in our intake paperwork. And you can reach out to me separately if you got questions about that. I actually do a lecture on that for our interns.
Perfect. Well, we are out of time. Dr. Courtney, you knocked that one out of the park. That was a great talk. I think a lot of us out here, and certainly in my addiction clinic, that's that crossover between pain and addiction that is a big part of my day frequently. Sure. So just loved your talk. Love to have you back again down the road. I'm sure you've got all kinds of things, other talks and stuff down the road. But yeah, really interested to see where some of this goes for you.
Too. Yeah, we've actually got a new grant that just came through yesterday where we're going to be doing some suicide prevention work with pain. So lots of exciting things. It's never dull around here.
Perfect. All right, everybody, thanks for coming. We'll see you in a couple of weeks, and we're going to talk about some of the drug trends. Again, that's always a great talk, so make sure you come back and see us. So everybody have a good week. Take care.